Good evening, everybody. I'm Dr. Sanjiv Jasuja from Indraprastha Apollo Hospitals, New Delhi. I'm going to spend another 30 minutes with you talking about the role of Cytosorb in the management of sepsis in the patients which may have AKI or without AKI. Now, this talk would flow in these three subsets. First, we'll talk about the epidemiology and mortality trend in sepsis. Then, we'll talk about the pathophysiology of sepsis. And finally, the modality of option for extracorporeal therapies. Particularly, we'll talk about the Cytosorb. So let's move on to the first part, epidemiology and mortality trends in sepsis. If you look at the sepsis incidence in a year's time in the United States, it's close to 1 million, and this number is close to about 1.5 million in Europe, and this number touches to about 18 millions if you look at the entire global population. And this trend is far more common in countries of third world and African subcontinent. As an Indian, we count around 17% of the total global population. If we try to derive from this denominator of 18 million global sepsis population in a given year, we may have a patient burden of about 3 million patients in a given year who develop sepsis. And in sepsis, the mortality rate is close to the tune of about 30%. That's one third of the patients die. And in India, that if you look at about 10 lakh patients annually, we lose their life because of sepsis. But with like in there's a bit of a silver lining which we have started appreciating in last one decades, maybe because of the antibiotic sepsis bundle and the kind of newer strategies which have started evolving. There is probably a perception which is coming up that the sepsis may actually maybe receding in terms of its numbers. Now, this is the data which has come from England, though it's about a decade-old data. If this is the all-cause mortality or the death rate per 100,000 general population in England, the upper half of these bars, at the bottom are the years, which starts from 2001 to 2010. And if you look at the upper half, the gray part of the light gray of these bars, it represents the population which probably had the sepsis as a cause of their mortality. And if you go around in this particular data, after about 2007, these bars are probably started showing a little bit of a downtrend, or it's relatively smaller as compared to what we had probably when we're looking at the data which had emerged from 2006 and 2007. The similar kind of data from Martin criteria, Angus criteria, which are used by the assessment of sepsis in insured patients, or then the trending from the multi-center clinical trial, particularly the regression analysis of these trials from US, also has started showing the similar kind of a trend. And very similar trend has been observed from Australia and New Zealand. But there's a serious caveat around this particular observation. Now, this caveat is probably the Will Rogers phenomenon. Our science, particularly as it's evolving, every passing decade, every passing year, there's more perceptual understanding of the disease, and more training and disease recognition patterns are evolved in terms of diagnostics or clinical criteria. On the basis of that, the number of recruitment increase. That means the denominators increase. Once the denominator of a particular disease increase, the recruitment number which is going up may include patients which do not have a very serious disease process. Then the recovery process or the survival numbers automatically increases. Now, this phenomena is called stage migration or Will Rogers phenomenon. On that basis, probably one of the good reasons that this trend which we have started emerging. Now, if you look at this particular data which has come from New Zealand and Australia, in 2000, the numbers of the patients reported with sepsis is about 2,700, and they grow by 5 times by 2012. Now, the denominators has increased, probably the recruitments are better, and the lesser category patients being included probably are representing some kind of regression. Now, whether it's true or not, we need to really quantify to the hardcore endpoints to be assimilated from the data which originated a decade back from the data which is coming up now. Now, let's assume that this is silver lining. Now, we move on to the second part of discussion, that is the pathogenesis of sepsis. In last one decade, there's been a serious change in our understanding about the sepsis. The sepsis, which was considered only as an onslaught of on the human body by pathogens or the inflammatory processes, is now also considered to be a very important aspect of our host response. And the principal host response cells which actually take onslaught and react to any kind of a sepsis situation, they are primarily the neutrophils, macrophages, and the antigen presenting cells. So they're the first line defense mechanism in the body which starts taking and start reacting to any situation which is coming to the human body. Now, if you look at this particular cartoon, assuming this to be the cell line, when the cells are exposed to the antigens, which whether these antigens are self-generated from within body because of the damage which is happening in certain situations like acute pancreatitis or any kind of post-surgery or crush injuries, where the antigens need not to be coming from pathogens. They may evolve from within the system. What these antigens are called DAMs, that is damage-associated molecular patterns, or the antigens which are coming from hardcore pathogens as a part of post-infectious disease process. And these particular antigens which are coming up are called pathogen-associated molecular patterns, or PAMs. Now, very interesting thing, these PAMs and DAMs are recognized by a very specific receptors, which are called molecular pattern recognition receptors, sitting on the cell surface of activated antigen-presenting cells, or the macrophages or the neutrophil cells. They start recognizing. And very important part which one must differentiate is that once there is a cell damage, there is a liberation of these DAMs, what we call as damage-associated patterns, which are also called alarmins. These includes basically the protein B1, protein S100, circulating DNAs, RNA, and the histone, etc. These are recognized on the cell surface by at least 4 kind of recognized receptors. They are toll-like receptors, seed-type lecithin receptors, nucleotide binding oligomerization domain-like receptors, retinoic acid inducible gene 1-like receptors. Now, another question which would come to everybody's mind, how the antigens which are being liberated from the damage of native cells are similar to the antigens which are being generated from the pathogens. For that, we have to go back into our historical development of human body. If you look at this particular part of the cartoon now, you look at this, the bacteria and human mitochondrial, or the eukaryotic cell generation over the millions of years has probably still retained some kind of a hardcore similarity within the deepest inner boxes. And if you see the DAMs which are being generated from mitochondria, they include formyl peptides, and the similar formyl peptides are liberated from bacterial degenerations. And bacterial DNA and mitochondrial DNA still has a lot of similarity, so that they can incite and they can be recognized by the pattern recognition molecules sitting on the cell surface of the antigen presenting cells, or the cells or the native innate immunity cells which need to react to these antigens. Now, with this important understanding, now if you look at whenever there is an onslaught on the cell or the human immune system, now which also depends, if it is pathogenic basis, it depends on the load, virulence, and the quantum of antigen being exposed on the part of pathogen, as well as the host responses, which is the environmental, genetic, age, and the comorbidity and the kind of medication plan one depends on. As a co-mixture of these two components, there's always a reaction evolves. Now, the reaction which it evolves in the body as an onslaught to any infection or inflammation status leads to 2 kind of responses. Now, this cartoon, if you look at it, upper half, which is red one, and the lower half is blue, which is a depiction of the 2 kind of responses which are generated in human body. Now, these responses include pro-inflammatory response. The excessive of this kind of response can lead to a collateral damage in the form of tissue damage, and then there is an anti-inflammatory response, which leads to some kind of energy in the body, and that can be a reason for the second onslaught of infections, when the body stops reacting to the all kind of infection, and the immune system starts getting in a kind of a recession where it cannot react. Now, the first part is the pro-inflammatory responses is generated through leukocyte activation, complement activation, coagulation activation, and then of course it leads to necrotic cell damage, and this necrotic cell damage leads to the production of dams, and these dams again get into the circulation and activate the more and recruit more and more inflammatory cells into the process, and this process is a vicious cycle which gone on, which continues to as an ongoing process. Now, another important aspect, which is observation of regarding the anti-inflammatory response, which almost starts simultaneously. Now, this operates primarily through the neuroendocrinal regulations, which includes the parasympathetic pathway activation as well as the adrenal gland, and finally leads to inhibition of pro-inflammatory cytokine productions. And this is also carried forward by impaired function of immune cells, which leads to the apoptosis of T and B cells and dendritic cells. And it also there's a change in transcription. The pro-inflammatory cells transcriptions get downtrending, while the anti-inflammatory the pro-inflammatory gene transcriptions gets an uptrend. So as a net result of that, a very strange kind of a status is achieved in the body where there is a pro-inflammatory responses. Simultaneously, there is anti-inflammatory responses, and all these responses create a very peculiar situation. That is what is primarily called the sepsis or septic shock. Now, this situation, as I just said, is a very peculiar situation. Ashutosh Shukla had tried to emulate the situation in a very in a mathematical model, where if you see this red bar is representing the pro-inflammatory arm, which starts a bit before the anti-inflammatory arm, and there is a bit of a difference in these two arms where they operate, as the observation on experimental models have been made. Now, there is a peak for pro-inflammatory arm, and then comes the peak for the pro-inflammatory arms. So this leads to formation of three different segments in patients or the experimental models outcomes. So first is a state where this is called adaptive immune response, or the phase 1. There's a good going possibility that this adaptive responses will meet to merge to a point, and a bottom line is achieved from where the patient starts showing a recovery. But in a cytokine storm-like situation where the pro-inflammatory arm takes a profound lead in the whole situation of a given human or a given patient subject. Now, once this takes up the shape, there's a good going possibility because of the inflammatory profoundness of the cytokine liberation which happens in the human body at that point of time may lead to the patient death. And then eventually this starts receding, and energy or process, or what we call it anti-inflammatory arm, starts taking the upper role in the situation, and then comes probably when the patient's immune systems are actually fairly down regulated, which is phase C. We'll talk about this cartoon later also in terms of adapting the different modalities for the treatment of, as a part of the treatment strategy into these phases. Now, if you look at this in this particular state, sorry for this mispositioning of the slide, but if you see what is the net results of pro-inflammatory and anti-inflammatory responses, is a massive cytokine release and a multi-pronged defects which are interlinked to each other. They lead to final formation of hemodynamic collapse, hypoxic respiratory injury, shock state, acute renal failure, disseminated intravascular coagulation, coagulopathy, and hepatic dysfunction, and eventually it would affect the neurological status of the concerned person as well. Now, this is a very interesting slide. This has come from Dina Cruz's group, where they've tried to describe the state of pro-inflammatory as SAD and anti-inflammatory as energy state, and this balance between the two states is described by them as a destructive immunological dissonance. Now, dissonance is generally the concording tunes of the musical tune which are not rhythmic. So that kind of a non-rhythmic kind of state is actually incorporated in an inflicted human body. So when the SARS are up, it's pro-inflammatory. When the energy is up, it's an anti-inflammatory state, which is both of these are non-desirable states which starts operating in the human body at a point when the sepsis sets in. Now, the same thing if you look at is this can be another way description is that there's a innate immunity acceleration to start with, simultaneously adaptive immunity, which is a anti-inflammatory state. Now, because of innate immunity, once it starts into its acceleration, there's a good going possibility of early death because of overwhelming inflammation. But once it starts receding, there happens a late death due to the persistence of immunosuppressant and recurrent possibility of recurrent infection because of the low or energy state in this population. Now, all this understanding, which I had just talked about for the last couple of minutes, has led to a serious change in our definition of sepsis. Now, this is if you look at we had 3 consensus conferences to describe the sepsis. The first 2 conferences are always taken in account for the sepsis and the sepsis-induced hypertension, sepsis-induced hyperperfusion state, or the sepsis or the septic shock state, as a principally incriminated towards the pathogens only. But in 2015, when we revised our definition on the basis of understanding which we have come up about the human body, we described that sepsis is a life-threatening organ dysfunction caused by dysregulated host response to infection. So we started incorporating another dimension, that is dysregulated host response. And since we have started understanding it, now this understanding would definitely evolve a strategic intervention towards this also. Now, if you look at the current sepsis management, this is the patient which I'm sure you're all familiar with, which you every day in, day out, all of us who are working in ICUs will come across such patients. Now, what we provide such a patient in the treatment, we give them respiratory support, we give them hemodynamic support, we give them renal support, we give them altered medication, we hardly have anything to offer. We provide them antibiotics, we provide them inotropes, and we actually, if you look at it, the whole picture suggests that what we treat is organ dysfunction, and we try to kill the pathogens by infection-related treatment strategies. But what we forget to treat in this situation is the sepsis. The sepsis, which is set in this system, in this body, is not the pathogen at this point of time. It is not the end organ which is failing. It's something else which is in the medium, which is flowing all across, in between, and that's what we need to work around. Now, if you look at that antibody for infection, we use antibiotics. For sterile kind of inflammations like burns, etc., we provide them a specific treatment strategy. Organ failure, we provide the organ support strategy. We need to work around in this central medium, which leads to the transmission from this end to this end. Now, this is a cytokine storm. So, what do we have to offer to a patient to act on these cytostorms? A lot of strategies have come up, but still a few of them have actually seen the clinical care, like extracorporeal cytokine removals and steroids, immunoglobulins, etc. Now, with this background, now we move to, since I'm concentrating only on extracorporeal therapy, that too primarily the Cytosorb, let's look at the modality option for extracorporeal therapies, what we have. Now, this is a list of extracorporeal therapies that we can offer to a patient to remove probably this cytokine process, which includes the high volume hemofiltration, high cutoff membranes, polymyxin columns, coupled plasma filtration adsorptions, cytokine adsorbing columns, renal assist device, RAD, or EISS, that's extracorporeal immune support system, and leukocyte inhibition modules, LIMS, what we call it. Last 3 are actually the cell-based, more of experimental kind of strategies which we do not commonly use, but all other are currently in clinical practice. But I'm going to, as I said earlier also, I'll just concentrate myself on the cytokine adsorption column, which is non-selective removal of inflammatory mediators and through plasma adsorptions. Now, this is what I'm talking about. Now, the Cytosorb is one such molecule which probably has been tried at least in sepsis, burn, surgical sepsis, pancreatitis-induced inflammation or SARS syndrome, hepatic dysfunction, life support system, ARDS, and influenza, etc. That's what exactly is this? This is probably to restore the balance. Now, this is actually nothing but a pilation of porous polymer polystyrene beads in a cartridge format. And the special characteristic of these beads is they are highly biocompatible porous polymer beads, and they remove by hydrophobics all the hydrophobic substances by virtue of their physicochemical properties and the pore size. This is not a diffusive or convective process. This is not a filtration process. Rather, it's an adsorption process which takes place. And it depends on the concentration. It doesn't remove all the molecule, but it removes a particular, the higher the concentration, there's more removal. The lower the concentration, there's less removal of this. Now, if you concentrate on this part, this is very important. If you remember the old hypothesis, which was given some point of time by Ronco and Bellino, the peak concentration hypothesis, though it was in relevance to the continuous renal replacement therapy, but the similar kind of upper peak cuts so that the reharmony between the SARS and energy process or the pro-inflammatory and anti-inflammatory cytokines is achieved by virtue of removal of these substances to some level, not to the complete depletion level. Now, other characteristic of this particular cartridge is that it's very large surface area, and this is non-selective kind of concentration-based removal of these, and it's pretty easy of the cytokines, but it's easy to remove. It's pretty easy to set up this if your patient is having hemodialysis. You can add this filter to the dialysis process. Then it needs to run to about 6 to 8 hours. If you add the same process to slow low efficiency daily dialysis, or what we call it SLED, then you might have to run it for 8 to 12 hours. And if the blood speeds are even slower, that means CRRT with 100 to 150, you need to run it for 12 to 24 hours. And as I said, the surface area of this cartridge is extremely big size. This is the comparison. If in comparison with the dialysis cartridge, if you look at the dialysis cartridge is roughly about 2 meters square, while the surface of this the small beads, if you put them, the total surface area is about 45,000 square meters, which is equivalent to about 4 football stadiums as compared to one single table of table tennis. So that's why probably in my clinical practice, once we put up this Cytosorb cartridge to my patients, we continue to monitor the patient hemodynamic improvement and let the process continue even for more than the designated period which has been manufacturer's guidelines, as long as the patient remains stable. And we feel, because the surface even in 24-hour time may not get saturated. Now these are the various mediator substances, the cytokines, which are being removed by this process. Most of the dialysis which we do, they generally remove between about 5 to about 15 kilodalton molecules, while adsorption by the Cytosorb process removes between 10 to about 50 kilodalton molecules, which includes IL-18, HMG, B1, IL-6, TGF, beta, etc. And the molecules which are bigger in size, like albumin, by virtue of their concentration gradient being lesser as compared to the interstitial compartment and the vascular compartment, their adsorption does happen, but it's not of any clinical relevance. Fortunately, the bigger molecules like immunoglobulins are not adsorbed by this column. And then certain other relevant materials which can produce some kind of a tubular injury, like bilirubin, myoglobulins, free hemoglobin, and bile salts. They're also adsorbed by the column. Now, this is again what I just talked about, that you can set it up as an hemoperfusion, you can set it up as a CRRT, you can set it as a part of ECMO process, you can set it as a part of CPB, that is coupled plasma filtration. Now, coming back to this carton, which I had already shown it to you, what should be our ideal timing to start this process in a given patient? As I said, this is the phase of inflammation, pro-inflammation and anti-inflammation. This starts when the human body is injured or inflammation incitation process by virtue of PAMS or by virtue of sterile injury leading to damp formation, whichever the two is happening. Now, this leads to the excitation of both of these arms together, but then there's a process in initial phases where both of these would culminate into some kind of a reaction which starts receding on its own, and probably the basal state is re-achieved and the body recovers, which happens with most of the infection which we acquired in our system. But in a very severe infection or severe insults, the pro-inflammatory reaction is much, much more profound, which is probably the phase two, which is called cytokine storm. And now this is a time where probably there's a role of any kind of extracorporeal therapy which can remove or the reset the targets for circulating immune mediators in the body. And then when the energy takes over, or that means the anti-inflammatory arm is far above the immune systems of the body starts showing a downtrending in itself. At that point of time, probably you have missed the boat if you try to, after this particular period, if you try to get into some kind of strategic intervention. This is the observation for most of the clinical trials. If you have not incorporated your strategy well in time and you've missed the initial boat, probably in this particular phase, or the phase C, what we call it, extracorporeal therapies or any other strategy has not shown any kind of outcome effect. So what does this mean? This means that you have to act when there is the first sighting of fire, rather than the entire house is doused. You probably cannot make it reverse back. Now, when should we start? Let's look at the discrete points where the Cytosorb therapy should be started. When the patient who has probability of inflammation and cannot be stabilized clinically by standard medical management, this is the time to start. And the clinical picture of hyperinflammation, which is either in the form of the shock, which starts setting in the last 24 hours, or patient is requiring epinephrine more than 0.3 microgram per kg per minute, and the dose is very rapidly increasing. And if the patient is developing signs of positive fluid balance in terms of some drop in urine output, third spacing of fluids, fluid in the lungs, and the stiffening of the ventilatory parameters, etc. The development of at least more than one organ dysfunction, whichever you start appreciating, whether coagulation or liver or the kidney or the lung or the neurological, whichever it's there, or you can sometimes pick up some of the biochemical parameters like procalcitonin more than 3 microgram per liter, particularly in the bacterial infections, or if the IL-6 level goes up more than 500 picograms per ml. So these are the few hardcore indications, because if you look at the patient survival as per Apache score, once the Apache score is more than about 30 or and above, the mortality rates goes far above 40% or to 50%. And similarly, when the organ failure, organ dysfunction starts exceeding 2, these numbers go much, much higher. With every further failing organ, the percentage of patients the dying because of the sepsis is far, far higher. So we need to probably work around, as far as Apache is concerned, between 25 to 30, 32. And similarly, around when the patient has got one organ and there's a possibility of another organ getting involved, that should be the ideal time when we need to start this. Actually, recently we have developed the patient selection criteria checklist tool, which was created as a uniform format by Indian Society of Critical Care and some of the partner nephrologists associated along with that, though it was a Marcon initiative. We clinically use this particular format to select our patients for the usage of Cytosorb whenever we are using it. Now this has 5 profound criteria, which is hemodynamic parameters, renal parameters, respiratory parameters, lab parameters, and sepsis scores are accounted for it. And each of these designated parameters have 2 or 3 subset of parameters, which are also accounted for, which for their scaling between 1 to 3. Now, each of these parameters in a particular given set of a patient, whichever from one particular segment has the highest value, that is chosen as the severity score and is put it in this column, and finally all these columns are totaled at the end. And the maximum number of scores which you can achieve is 15, and this because the 3 to all the 5 is 15. Now, as long as the patient has a score of 8 or less than 8, this is the time then you should start apprehending that you probably touching close to 8. That means you have probably maybe requiring the usage. Now, this perception starts coming to the physician who's closely monitoring or treating these patients on a regular basis. Now, once the figure or the total of these scores exceeds from 8 and it between 8 and 13, this is probably a definitive indication that we should incorporate something more than a standard care, whatever we are providing to the patient. But once it exceeds 13, well, you can use it, but probably the outcomes are going to be poorer. Once Another important question is you have started a cytokine therapy in the form of Cytosorb. What is the end point to this? Now, the definition of Cytosorb treatment depends on clinical improvement, the duration, and the treatment should be continued till the stabilization is achieved. There's uh, no need for catecholamine once the catecholamine requirement starts decreasing or there's a reversal of fluid balance, that patient is passing adequate amount of urine, there's normalization of lactate level, or there's improvement in an organ perfusion, particularly the ventilatory support system, and the lungs become relatively less stiffer, and there's a return of spontaneous diuresis, a patient starts maintaining a better pH, liver functions, serum albumin and serum alkaline phosphatase start showing some improvement trend. So these are the definitive hard points from where on you can stop the additional support from the standard care what we have incorporated. But generally, if I share with my experience, we have to use at least 2 or maybe 3 cartridges. I've used maximum about 4 cartridges in a patient where there was a consistent improvement, and whenever we stopped the cartridge, we thought around third that probably we can stop it at this point of time, but since the patient started deteriorating, we had to reincorporate the cartridge support to this patient. Now, what is an evidence? There's enough literature which has been written about particular this particular. I don't think there's any other adsorbent strategy which has so much of papers written. I remember a couple of years back when the Dana Cruz and others were active around. There's another cartridge, not naming that, but still the literature which has come up for Cytosorb is far more profound because of its easy use, safety profile. And it removes IL-6, improvement in hemodynamics, reduction of vasopressor needs. Probably this also improves the capillary leak syndrome because of these. Apart from the patient outcome, these are the hardcore other benefits which we achieve out of this strategy. That's why all these parameters have been looked at by different trials without actually at times not looking at the hardcore outcome in terms of patient outcomes, but still these have served as a parameters to look at strategic intervention success. This is a very important study which includes which talks about 26 patients. Something very interesting to look at it, and they incorporated this strategy with the different timelines to these patients. What they found, the strategy worked only in those patients when the sepsis was less than 24 hours, less than 24-hour duration, and the improvement when in a subset of patients, about 50% of these patients, where the predicted mortality of 93% was reduced to about close to 70%. There was serious 22 to 23% improvement in mortality rate of this population, but this was not seen when the strategy was delayed more than 48 or less, between 24 to 48 hours even. Yeah, this is the same. Apache predicted actual mortality versus the outcome in this particular trial. Now, this is another trial which was also published in 2017 Journal of Artificial Organs by Sigrun, which included 20 patients with refractory septic shock. 28 days survival was 45%, while the predicted SOFA score mortality was 80% in this population. Now, these two trials, the first and the last one I've already talked about, the previous one. There's another trial which had initial Apache of 39, and expected mortality was close to the tune about 90%, was reduced to about more than 69%, and about 28% reduction in mortality was observed in this trial as well. This is published sometime in 2016. We have some data which is not published but has been presented in ESICM 2018 31st Annual Congress in Paris on October month by Max Hospital, New Delhi. The title of this presentation was hemoadsorption by extracorporeal cytokine adsorption therapy, Cytosorb, in the management of sepsis, a retrospective observational study. In this study, they included 36 patients and they ran the process for about 12 hours. And Cytosorb used average run for about 12 hours. The Cytosorb used as an adjuvant therapy to standard of care as per sepsis guidelines. What they found in their patients, the procalcitonin level significantly came down, 38% reduction in TLC, shock reversal in about 66% of patients, and mean SOFA score also came down. So there are overall hemodynamic improvement has been reported from this Indian study as well. Then there are a couple of small studies which has used this cartridge, like in this Legionella pneumonia where there was a rhabdomyolysis associated. The study could the usage of cartridge discretely showed with the application there was a very marked reduction in myoglobin levels in this patient. Patient survived finally after 3 or 4 cartridges. A similar kind of observation, particularly, has been Stephen Butner has shown instead of providing a standard care liver support system, they used Cytosorb as a liver support system, and they could document a reduction in bilirubin, ammonia, bile acids. But this is not a conventional treatment strategy. But yes, it is something which area which needs which is worth the exploration. At least I have not used in this particular indications. Before I culminate, I would just put some points which I would prefer that we should all remember. Antibiotic most commonly used as a first line strategy, which we are all aware. Antibiotics, whether all kind of antimicrobials, depending on sensitivity or a broad spectrum. Optimizing antibiotics use improves the patient outcome is a hardcore fact. As the adjuvant treatment in conditions of elevated cytokines, Cytosorb offers an adjuvant approach supporting the immune system to regain homeostasis, which invariably is observed in majority of patients irrespective of the final outcome. Promising clinical results derived from randomized control trial, case studies, reports, ongoing single center studies, increasingly clinical evidence. Dear friends, I just would like to put it, all those, I'm sure you must have clinically used this therapy, and I've been practicing this therapy. Despite the global data which have emerged, what we have seen is a very significant hemodynamic improvement, because the co-variables in these patients, there are so many that to really, despite capturing on improvement for a while, may not actually translate into the patient outcome, but eventually it gives a leverage to the treating clinician to probably buy time and to act upon on the associated areas which standard care is available, probably to extending these cares and improving on the standard care inventories. Probably we can improve the patient outcome along with these kind of support systems. Since there's no alternative to thinking, with these very words, I would say thank you very much for being patiently listening to this talk. And now it's open for any kind of discussions. Thank you very much.